Welcome everybody to this afternoon's breakout session, Improving and Expanding Analytics, New Uses for Claims Data. Deb Gray from the Center for Health Information Analysis in Massachusetts will moderate this session. Deb?
Thank you, Norm. Thank you everyone for joining us today. And I promise we have a great, very exciting session ahead of us on improving and expanding analytics, new uses for claims data. We will follow the format that a number of the other presenters have had, which is roughly 8 or so minutes for presentation, followed by questions immediately after the presentations. I would encourage the audience to use the Q&A button while we are presenting to have a timely recording of your questions. And without any other ado from me, I would like to introduce our first speakers. That will be Dolores Yanagihara on serious illness, medication, safety, adverse drug events, and utilization outcomes, an evaluation of 15 million Californians using claims data. So thank you. And Dolores?
Are you on mute, Dolores?
I am just trying to pull up my presentation. I think there's a little bit of a delay.
Okay.
There we go, share file.
Looks good.
All right. There we go. All right. Well, good afternoon, everyone. My name is Dolores Yanagihara, and I'm with the Integrated Healthcare Association in California. We're a nonprofit organization that plays the role of a neutral convener, bringing together all the healthcare stakeholders to really focus on addressing industry pain points. And one of the things that we do is run a voluntary APCD. IHA contracts with OnPoint Health Data as a data partner. And so Carl Finnison from OnPoint and I are glad to be here today to share a study that we've conducted on serious illness. And I'm not seeing, oh, here we go, next. Okay. There we go. We all have lots of examples of our fragmented healthcare system. And this can be especially challenging for people with serious illness. There's an increased awareness of serious illness, and payers and more recently healthcare systems are really trying to develop specific programs to address this. And yet most of the evidence and work that has been done to date has been done on Medicare fee-for-service. So a part of the purpose of our study was to really expand beyond Medicare fee-for-service and use our APCD data to identify members with serious illness in the commercial and Medicare Advantage population, as well as Medicare fee-for-service, and then look at the types of care that they are receiving, and looking at the variation in care, both by types of service, but also across different geographies. In particular, we used counties and CBSAs. There were several organizations that contributed to this study. The funding came from the Gordon and Betty Moore Foundation. They have a serious illness portfolio, and we're really trying to understand what that looked like at a more population level, and to see if there were certain geographies that could benefit from some community investment. And then Duke Margolis Center for Health Policy had done some work in this area, and they helped with the definitions of how to use claims to identify serious illness and some of the high-risk medications that we'll talk about. OnPoint then used the APC data to identify members with serious illness, and then created a summary of utilization, and IHA and Duke Margolis analyzed the results. So our study included just over 15 million members that are adults in commercial or Medicare. We focused on adults only. So we split it into 2 age groups, from 18 to 64, and then 65 and over. Our first line of business was really to confirm the definition of serious illness. And so There were really 3 criteria that we looked at, and this work was led by the Duke Margolis Center. And so the first criteria focused on a medical condition. So people to qualify had to have either at least one serious medical condition, like COPD or CHF or dementia, or have 3 or more chronic conditions. So the first criteria is medical condition. The second criteria is that the person had to have at least 1 inpatient hospitalization in the past year. And then the third criteria was around functional limitation. Now, this one was challenging because there's no code in claims that says you have a functional limitation. And so we needed to kind of use surrogates for that. And we used skilled nursing facility, home health, and DME. Because the functional limitation is a bit challenging and is a surrogate, we decided to actually have 2 different definitions, one that included the functional limitation and one that did not include the functional limitation. And then as a control group, we had those members without serious illness. The types of things that we looked at different kinds of medical utilization, so inpatient admissions and readmissions, ED visits, both avoidable and total, and some office visits. We also looked at pharmacy utilization in terms of total medical medications used, but also the number of different medications that were used, with particular focus on high-risk medications. And again, OnPoint and Duke Margolis Center worked on getting the right medications and the right codes for those to identify those. And then lastly, we looked at adverse drug events. And now I'm going to hand it over to Carl, and he will walk us through the results.
Thanks, Dolores. Just wanted to mention that Amy Kinner at OnPoint did quite a bit of work on this project. I'm just going to quickly go through about 6 graphics here to give you an example of some of the information we produced. Obviously, one of the key points of it was to look at serious illness and find people. And so we looked a lot at prevalence rates. Overall, we found 1.1% of adults 18 to 64 and 8.5% age 65 and over had serious illness. Prevalence rates by county ranged from a low of 6% up to 13%. Go to the next slide. So this slide simply shows rank orders within the various different categories of different conditions. Overall, we identified 27 different chronic conditions using the chronic condition warehouse definitions. And so, for example, arthritis, diabetes, heart depression, and COPD were high through all the groups. And then congestive heart failure was high for the serious illness group. Next slide. We looked a lot at utilization in terms of emergency department visits. We had overall half of the serious illness had at least 1 ED visit, while only 10% of 18 to 64, 16% of 65 without serious had at least 1 ED visit. Turning to inpatient, obviously part of our definition, so you see the 100% people had to have a hospitalization during the year in order to be qualified to be seriously ill. And we did look at readmissions and found higher rates among the serious ill population. Next slide. So continuing on with our descriptive statistics and rates, we looked a lot at pharmacy information and found significant higher rates of multiple pharmacy use, sometimes called polypharmacy, among the high-risk population. Let's move on to the next slide. So this is a ranking. We already showed you information about by county. We also used core-based statistical areas, CBSAs, and found wide variation amongst the geographical areas. We looked at prevalence, ED visit rates, inpatient discharge rates, and prescription rates, and also created, there was a composite measure created, which is the leftmost column there. And so, for example, Modesto ranked the highest, while Santa Cruz area of California ranked the lowest in terms of the overall composite measure. Next slide. So we looked at adverse drug events in great detail. This is another ranking slide showing that actual adverse drug reactions were a leading cause for the serious ill population. And this is quite a distribution on lots of different descriptions of adverse drug events.
We're at 2 minutes.
I'll turn that over back to Dolores.
Mute check.
I just realized I had my microphone off. My apologies. I was doing my conclusions to myself. In conclusion, we believe that we found a methodology that did identify those with serious illness, not just in the Medicare population, but also the commercial population, and saw clear differences in the amount of services used. Interestingly, the types of conditions, the drugs used, and the reasons for visits were actually quite similar between the seriously ill and the non-seriously ill, but clearly a difference in the amount of those. We also found that the seriously ill have a much higher, or there's much higher numbers of seriously ill as you get older. And so as our US population continues to age, it'll be important to understand this population even more. We did have some results published in the American Journal of Managed Care in July of this year. And so we're happy to share that with anyone who's interested. In terms of policy implications, CMS is really focusing on the seriously ill population. It's part of their primary care first initiative, as well as their direct contracting models. And so it's helpful for them to be able to have some numbers that they can compare to in the not just the Medicare fee-for-service population, but a broader population. The movement to value-based payment and with clinical entities taking on risk, it's really important for them to be able to manage costs effectively. And understanding the seriously ill population is one important aspect of that. Really understanding if there are particular types of services that they might want to focus on, or conditions, or specific geographic areas that might benefit from some intervention. And we actually used this study as a basis for a resource mapping for COVID. OnPoint overlaid some publicly available hospital capacity data onto our prevalence of serious illness data, and was able to look at where there may be shortages of resources based on just the seriously ill prevalence and their propensity toward maybe being more susceptible to COVID. So anyway, we're happy to share our methodology and hope that it can be a solid starting place for others to build on. Thank you.
Thank you. I see we have a question from Jim. How did you determine whether or not an ED visit was avoidable?
Carl, are you able to speak to that?
Sure. Actually, I believe it was based on Oregon study. I'd have to double check with Amy Kinner on that. It's not available, but I think there was a definition that came out of Oregon originally that was used to determine avoidable ED visits. Most of the ED visits were not avoidable according to that definition for the serious ill population.
Great, thank you. So I understand that from my own experience as well, that time lags are a common complaint for APCDs. And so I'm curious, how are these findings relevant for supporting programs that need current data?
Yeah, no, that's a really good question and always a challenge. So I think when you think about serious illness, it is not something that likely is going to change dramatically over shorter periods of time. And so I think that, understanding the population still is relevant, even if it's, you know, a little bit older data, just because, like I said, you wouldn't expect it to change too much. Carl, anything you'd like to add to that?
Just to reiterate, most of the conditions, the 27 conditions that were used were chronic disease conditions.
Thank you. Well, thank you for that very interesting presentation. If there are no more questions, then if anyone in the audience were to think of something later, please feel free to follow up with the presenters. And at this point, I believe we're turning it over to Mary Kate Molman and Jesse Drummond to share with us their findings on using state APCD claims data to identify children with high mental health needs to improve access and reduce inpatient use. So thank you.
Hello, let's see the plug.
Are you having trouble with your slides?
Taking a moment. Yeah, it's not clicking on it. I'm trying to pull up the file.
Okay. Do you have a copy, Norm?
Oh, wait, hold on. All right. Works. No, not coming up. Do we want to try it on Norm's end?
Okay, I just loaded up. There you go.
Great. I can see it. Thank you.
Oh, okay. Okay. Sorry, mine is. So to get started, not showing up on my. All right, well, I'll just get started and I'll see what I can do to advance the slides. Or I guess it's Norm, you're the one who's going to be advancing, correct?
Yes, that's correct.
Okay, there, I see it now. All right, so my name is Mary Kate Molman. I am the health services researcher with the Blueprint for Health at, in Vermont, or the Vermont Department of Vermont Health Access. This is the department in our Agency of Human Services that houses our Medicaid state plan. However, we're talking about an all-payer claims database, and you'll see why that is also vital, even though I'm coming from mostly a Medicaid perspective. So even though Vermont has fairly consistency, ranked pretty well in terms of its mental health system, we continue to have challenges. Often these are challenges with flow, and we've seen a number of patients, including pediatric patients, held up in the emergency department for multiple days waiting for a bed to open up. So while one thing we could try to fix the problem on the downstream and work on improving the flow through our mental health system, our Department of Mental Health and our Medicaid agency also started thinking about what can we do upstream to prevent the need for people even coming into the emergency department in the first place. And that got them thinking and developing a mobile response unit that would reach out to pediatric patients who showed indications of need and get to them before they even needed the emergency department. So with that program in development, we really needed to understand, well, what's the status quo? Who are the individuals who are using the system for mental health services, and who are the high utilizers of these mental health services? What are the expenditures that we're currently spending on mental health services? And should this mobile response unit get stood up, then also having a study that provides a baseline against which to evaluate the success of the mobile response unit. So that's where there's really twofold needs for this study. So to get us started on the study, we first needed to identify individuals, pediatric individuals who had a mental health diagnosis, a primary mental health diagnosis for the mental health services. And we limited it to individuals between 1 and 21 years. We often cut off individuals less than 1 just because their claims can be difficult, tied to, they're very sporadic. So we focus on the 1 and up to 21. And we looked at those who had, of the mental health services, a diagnosis of a mental health as a primary diagnosis. Secondly, and next slide, we wanted to stratify them into those that were high utilizers of mental health services and those that were not categorized, did not fall into that category. So working with our Director of Children's Services in our Department of Mental Health, which is also in the Agency of Human Services, and working with our Director for the Medicaid Quality Unit, we devised these criteria for identifying those who would be categorized as high utilizers. And you see hospitalizations, ED visits, residential services, and we set the criteria for more of the home and community-based or case management services. And then everyone else who was identified with having a mental health diagnosis was lumped into the non-high utilizer group. Next slide. And then of these populations, the high utilizers and the non-high utilizers, we looked at them in different ways, cutting them different ways. So we looked at them by payer type, by age group, by gender, hospital service area. Vermont has 13 hospitals, non-commuting hospital services. So it's a really nice way to break up the state and look for regional geographic trends. We also looked at this population by health status. So looking at the degree of complexity, and we also looked at them by SAMHSA mental health diagnoses. And the outcomes that we focused on were expenditures, total expenditures for mental health services, and inpatient hospitalization or ED visits with a mental health diagnosis. And I call that out because this does not include services outside of mental health needs. So it would be a regular primary care visit or an ED visit for a broken leg, for example. Just clarifying where those lines are. So now we're going to look at the results, and I'm going to turn it over to my colleague, Jesse Drummond at OnPoint, and he's going to pick up on the results.
Yep, thanks, Mary Kate. So I'm going to run through a few findings today to talk about these groups, this group of folks that we found. I also want to mention that Carl Finnison, who you just heard from in the previous presentation, was heavily involved in this, as was Amy Kinner. So big thanks to Carl and Amy for this. So what you're seeing here is a table showing the high utilizers that we identified. That middle column there shows the high utilizers. The column to the left of that shows the non-high utilizers, and then the column all the way to the right shows all members. Those, as Mary Kate mentioned, those are all members aged 1 through 21 who had a mental health diagnosis. And then on the left-hand side, you see a series of metrics, starting with the number of members. And right off the bat, the first thing that we looked at here, that we identified, is that of the roughly 35,000 members, our operational definition of high utilizer identified about 5,000. So about 1 in 7 folks fell into this group. The next several rows there are part of our operational definition. So it's not surprising that we don't see any folks in the non-high utilizer group show up with any of those criteria. But we do see all of them in the high utilizers. And then at the bottom there, we have our cost breakouts. So we have our total mental health cost, we have our average, and we have our medians. So for an analysis like this, especially for a high utilizer population, you would expect there to be some outliers. That's why we looked at medians as well as the average. But it was pretty striking to us that both the average and the median costs were dramatically higher in the high utilizer group than in the non-high utilizer group. And the difference was roughly the same, as about 10 times higher in the high utilizer than the non-high utilizer group. Next slide, please. So what you're seeing here is a few charts stratified by demographic characteristics. So at the top there, we see gender, and then age, and then product type. And then our non-high utilizers are in blue, and the high utilizers are in red. There are 3 columns there. The first shows the percent of members. The middle column is the average mental health cost, and then the column on the right is the median mental health cost. And a few things jumped out to us here. The first being that the average and median mental health costs are dramatically higher for the high utilizer group than the non-high utilizer group, really across all the stratification. So it wasn't as if all the high costs were subset to a particular demographic slice of our high utilizer group. A few other findings that we identified are high utilizers tended to have a slightly higher proportion of members who were male than the non-high utilizer group. They were also slightly older. So those categories, age 11 to 15, 16 to 17, and 18 to 21 were all higher in our non-high utilizer, in our high utilizer group. And then for product type, the high utilizer group had a higher proportion of folks who were covered by Medicaid. But it's notable here that we still had a pretty large group covered by commercial payers and some who had Medicaid, Medicare dual coverage. So we just wanted to highlight here the importance of including multiple payer groups or product types in an analysis like this. It's not strictly a Medicaid population. We do see folks from across the different product types. Next slide, please. So what you're seeing here is essentially a histogram. It's the total mental health costs and distributions for our two groups. So on the y-axis, it's the number of members, and then you have the different cost buckets on the x-axis moving across the horizontal axis, going from less than $1,000. This is the total mental health cost for the year, and going all the way up the bucket all the way to the right is $20,000 or more. And you can see pretty clearly here that the non-high utilizers, there were many more of them. A much higher proportion of folks in the non-high utilizer group had much lower costs than in our high utilizer group. In fact, there were very few members in the high utilizer group in that lowest bucket. And then they were fairly uniformly distributed across the next four buckets. So you're really seeing a high proportion of folks in the non-high utilizer group who had fairly low costs. And most of the folks in the high utilizer group had pretty high costs. So it's another way for us to start to analyze the cost differences. Next slide, please.
We're at 2 minutes.
So we also wanted to look at the health status of these folks, as Mary Kate mentioned. And one way to look at this is by CRG. So we have our CRG categories on the left side going from 1 healthy all the way down to 9 catastrophic, and these increase in complexity. And again, our non-high utilizers are in blue and high utilizers are in red. And you can see there that the non-high utilizers had a much higher proportion of folks who are healthy, and very few of the high utilizers fall into that category. And as you move up, you see more people in the high utilizer group with each of these CRG categories, especially as you look to number 5 there. Roughly 45% of the folks in our high utilizer group fell into that CRG category 5, significant dominant or moderate chronic disease category. Next slide, please. And finally, we also looked at this by the SAMHSA diagnoses groups. So we have our groups on the left-hand side moving down. Again, our high utilizers are in red and the non-high utilizers are in blue. And again, you can see here that our high utilizers were much more likely to have each of these diagnoses, or to have a diagnosis that fell into each of these categories. The only one where that was not the case is all the way down there at the bottom, the developmental disorders one, where there are actually a higher proportion of folks in the non-high utilizers than the high utilizer group. And we included this because we were initially curious as to how we saw some folks in that non-high utilizer group with such high costs, and thought it might be due to developmental disorders, conditions that wouldn't lead to the kind of acute episodes that would be included in our operational definition, but would still incur high costs. So we included that here as sort of a note of context about the costs for that group. And I think that's it for me. So I'm going to pass it back to Mary Kate.
All right. Okay. See, there we go. Next slide. There we go. So this is refers back to the hospital service areas that I talked about earlier, and I'm just going to go briefly through this. And I want to call attention first to that first column, and this is the distribution of counts of individuals who are categorized as high utilizers. Burlington as our by far most densely populated region, HSA. But then if you look at the ED visits, the inpatient visits, the inpatient length of stay, the distribution of those outcomes do not follow the same distribution of number of individuals. So the takeaway from here is that when you're looking at putting in a program in place, you don't necessarily want to look where the most people are. You want to really understand what are the patterns of utilization, what are the expenditures, and figure out where is an intervention most likely to be effective to hit that high rates of utilization. So this would be, maybe want to focus more on Rutland and Newport, according to this graph. Next slide. And these are our conclusions. So as Jesse mentioned, our high utilizer group had a higher proportion of patients who were male, older than 11, and enrolled in Medicaid. The average and median total mental health expenditures was approximately 10 times greater than our non-high utilizers. And they had substantially high proportions in all the diagnostic SAMHSA categories except for the developmental disorders. And the next point is basically what I said in the last slide. And then finally, the value of APCDs. If you were to take this the next step and work with multiple payers to implement an intervention for this population, you really want to, I think our data shows that you want to also bring in commercial payers as well as Medicaid and enroll Medicare as much as you can. Thank you.
Thank you. While we're waiting for some questions from the audience, while you folks were presenting, I was thinking a little about our current circumstances with the impact of COVID-19, particularly on youth, and not only just the mental health stress of this illness and the lack of the typical structure in place, those kinds of considerations, but there's also been some reporting about a number of children receiving mental health care in the schools. And as we all know, many of the school districts have decided that in the fall they will still have at-home schooling. I know this isn't exactly the topic that your presentation is addressing, but I'm just wondering if you had some thoughts or just a projection on how those changes might play out.
Oh, this is where I want to pull in my mental health compatriots.
Yeah, I know. Sorry.
I think the idea, especially as more and more people are, staying at home, getting school from home, limited school services, something like a mobile response unit. I'm just kind of spitballing here. Imagine that would actually be very valuable for these high needs kids. And when you don't want them to have to go to the hospital and you don't want them to be exposed, having someone who can come into the home and support those individuals in the home would be useful. Now that brings up a whole different set of like personal protection and what's available and the workforce that might be available to run something like this. And I'm thinking of home health has had its own challenges, but in a situation where there are no easy answers, I think our data shows that there are high needs. This is a really acute population or population in need of acute care. So any kind of intervention, prevention, care management that could be provided could be beneficial.
Thank you. That's great. Appreciate the thought and the response. I think that that's something that will probably lead to a lot of research, but certainly some of the considerations that you've taken into place will probably bear on that research. So thank you for that. And thank you for your presentations. And last but not least, we have our third presentation of the day, Balancing Billing Protection Act, use of Washington State's APCD to support implementation. And I believe Jane Bayer will be the first to present on that topic.
Yep.
Thank you, Jane.
Thanks so much. So I'm Jane Bayer. I am the Senior Health Policy Advisor to Insurance Commissioner Mike Kreidler, and I'm joined today by Thea Mounts from our State Office of Financial Management and Joanna Duncan from On Point. So we're going to talk to you today about how we have used our APCD to support implementation of our Balanced Billing Act. And I think it's a great example of using data to to support policy implementation in a relatively contentious environment. So, next slide, please. I'm just going to give you an overview of the substantive provisions of the Act itself, and then hand it over to Thea and Joanna to talk about how we use the APCD. Generally, I'm going to call it the BBPA, the Balanced Billing Protection Act in Washington State, applies to all fully insured health plans, our state employee health plans, our school employee health plans, and we've also given self-funded group health plans the opportunity to opt in so that they could provide these protections to their enrollees. We have over 100 self-funded employer groups that have opted in. And a provider can check whether a consumer's health plan is covered via a HIPAA standard transaction that is used commonly in the world of health insurance. Next slide. So as I indicated, a self-funded group health plan can opt in so that they can basically ensure that their enrollees have the balanced billing protections under the Act. It's all done in a web-based process. And for those of you who are familiar at all with ERISA, the Employee Retirement Income Security Act, states are prohibited from directly regulating self-funded group health plans. And so that's why our statute gave those plans the opportunity to provide the protections to their employees if they wanted to. Next slide. So as of January 1 of this year, surprise balance or balance billing is prohibited for services in an emergency room, whether it's an in-network or out-of-network emergency room, and all the emergency providers that go along with that, as well as non-emergency surgical and ancillary services that are provided in an out-of-network hospital in an out-of-network hospital or ambulatory surgical facility. And the specialties that are affected by this are surgery, anesthesiology, pathology, radiology, lab, and hospitalist services. Next slide. And essentially, when surprise billing is not allowed from the consumer's perspective, it's as if they have received in-network services. So their cost sharing is whatever in-network cost sharing would be. It's based upon the median in-network contracted rate that their insurance company has for the same or a similar service. Their explanation of benefits is going to look a lot like an in-network EOB, except that it's going to explicitly say whether a particular claim is protected under the Balanced Billing Protection Act, so that consumers know that they can't be balance billed. And any amount that the consumer pays is applied to their deductible or their out-of-pocket limit, just like an in-network service would be. Next slide. And just very quickly, no provider or hospital can ask a patient to limit or give up those rights. I think we're all familiar with the big stack of paper that one gets when one goes into a hospital, and we didn't want a waiver to be hidden in there in any way, means, shape, or form. Next slide. And we have developed a consumer notice with consumers' rights under the Balanced Billing Protection Act. We have also explicitly said when those notices have to be used. For example, when somebody has a procedure scheduled, like a knee replacement or whatever, at an in-network hospital, so they know that if they end up being cared for by an out-of-network anesthesiologist or radiologist, for example, they cannot be balance billed. And I think with that, I will turn it over to Thea.
Okay, great. Thanks, Jane. So I'll cover over the next few slides a bit about the data set that's required to be developed under the BBPA. So unlike many other states and
I'm sorry, I can't hear.
Okay. Is this any better? Can you hear me now? Okay.
Yes, thank you.
So unlike many other states and work underway at the federal level, Washington doesn't have an explicit benchmark for resolving balance billing disputes. Rather, the legislature passed the Balance Billing Protection Act, specifying that the out-of-network provider must be paid a commercially reasonable amount based on payment for the same or similar services provided in the same or similar geographic area. This approach was the end result of over 4 years of work with stakeholders, during which time no agreement was reached to establish a benchmark. Instead, if a provider and payer have a dispute over the amount to be paid for a claim, the parties can move forward with arbitration. Each party provides its best and final offer to the arbitrator, and the arbitrator uses the information provided by the parties, as well as the commercially reasonable amounts calculated for the Balanced Billing Protection Act dataset to determine which parties offer to select. So the data set is providing one possible source of information for the decision. Next slide, please. This slide outlines the timeline for the payment of an out-of-network claim in Washington, including the specific number of days between each step if arbitration is necessary. The timeline specifications are laid out in statute and in rule. Next slide, please. So as required by the Balanced Billing Protection Act, the Washington All-Payer Claims Database was used for establishing the commercially reasonable rates for use by payers, providers, and arbitrators. The state's database was critical to the BBPA work because it is a reliable embedded source of data. Data submitted to the Washington APCD pass through a standard submission process and undergo numerous quality assurance checks during and shortly after intake. In addition, the BBPA dataset was developed through a partnership between the Office of Financial Management, which was at the time the Washington APCD Oversight Agency, OnPoint Health Data, and the Office of the Insurance Commissioner, with involvement of health insurance and healthcare providers and facilities. The dataset serves as a neutral and credible source of information. Next slide, please. As required in statute, the dataset was to be based on the most recently available full calendar year of claims data, which at the time was the 2018 data for calendar year 2018, and only commercial fee-for-service health plan claims are included. It provides median in-network allowed amounts, median network out-of-network allowed amounts, and median billed charges, and is updated annually using the Consumer Price Index for medical services. More information is available at the link on this slide if you're interested. And with that, I'll turn it over to Joanna Duncan from OnPoint, who will present the dataset's key components.
Thanks, Thea. And now we get to the really fun part, right? Digging into the data and how does that connect to the APCD, and how do we get from the APCD to these policy choices. And when we were looking at this with our stakeholders, the real key was to focus on data elements that were impactful for the analysis. So one of those key items were the allowed amounts and the amount that were provided to us. And we wanted to ensure that we removed any records that might have impacted those dollar amounts. So for example, we only included records that were paid by the primary payer. Secondary and tertiary claims are excluded. We excluded denied or orphan claims. We excluded records where we only included records where the bill charge amount was greater than 0. So making sure that there were paid amounts. And the definition of total paid for us was the sum of the paid plus the member responsibility. The second key item for us was looking at how are we going to stratify this by geography. These median allowed amounts were going to be provided in a data set that was going to be used by the auditors, and we provided it at 2 levels based on the feedback from all of the stakeholders. Those 2 levels ended up being the OIC geographic rating region, and the second one was the statewide region. And these were decided based on ensuring that we had enough records to be statistically relevant. The second part of this geography is really to help us understand from the APCD, how do I get those records into those geographic rating regions? So there are 2 options. One option is to assign it based on the member zip code, and the second option is to assign them based on the rendering provider for the service. In this case, we're using the rendering provider zip code as the location for that service. And we would also exclude any out-of-state services at that point, or unknown provider zip codes, to make sure that we're using the cleanest data possible. Here's a quick example of what those OIC rating regions look like for geographic areas. And they're similar to the health service areas that Kate talked about earlier in one of her presentations. The third key breakdown is that all of this data set was stratified by the procedure code. And when we start to stratify procedure codes, modifiers come into play. And modifiers played a big part of our stakeholder conversations. And the reason they played a big part is because there are many, many modifiers that affect the pricing at the service line level. And so similar to our key item number 1, any modifiers that were used on the procedure codes that affect pricing were removed from this analysis. The second part for modifiers is that we stratified the data by 3 different modifier groups. And those modifier groups were the professional component and the technical component, and these were found in the radiology buckets. And then the third stratification was through the other. So any records that had modifiers that were null, no modifier at all, or were modifiers that were not included in the list here under the second bullet. So once we got through kind of what are the records that are included in the services, we started digging down into the different categories that Jane described earlier. One of the more challenging categories or service settings were the ED services. And these were more challenging because the statute required that we look at both professional services and facility services. The professional services are fairly straightforward, identified using an emergency department flag that is based on place of service codes and procedure codes, and easily identified in the data. But the facility records were much more challenging because these facility records were paid in a variety of ways. And so because of the variety of ways that they were paid, there were no apples to apples comparisons within the data. And we had to work with the stakeholder group to find a way to agree on how would we provide these median values to them. And the way that we did this was by applying an APC grouper. So APCs are ambulatory payment classifications. And by applying that grouper to all of the Washington APCD data, we now were able to group like claims together and compare data across payers. Once we've done this, we calculated median allowed amounts by each one of those APCs, and we were able to stratify those by geography. Now, in this case, we weren't providing median allowed amounts back out in the data set. Instead, what we did is we compared those median amounts in the APC grouper for the commercial data for these ED services to the same APC in Medicare. So you got a ratio of the Medicare amount by APC to the commercial. And that ratio is what is provided in the data set here. For calculating the rest of the non-emergency services, we use standard billing practices and standard billing groupings. So you can see for surgery, hospitalists, lab and pathology, radiology, anesthesiology, these are standard ranges that you can find for CHPT groups. Within these groups, we also restricted these claims where the setting was an inpatient or outpatient or ambulatory surgical center. And the final piece, and maybe if you went to the NASHP discussion today, you heard about anesthesiology. Anesthesiology was also a challenge here, and for similar reasons. So this methodology, also the same methodology that Oregon used, will provide a conversion factor by geographic area. So for each geographic area, you get one conversion factor that will tell you what the cost is for those anesthesiology services. And it requires base units, quantity, and physical status. What we found in the Washington ABCD is that the quantity was reported inconsistently, sometimes as minutes, sometimes as units. And so the team, the Washington ABCD team, took it to the next level and provided additional guidance in their data submission guide. And we're currently receiving updated information from our payers so that we'll be able to provide this information soon.
We're at about 1 minute.
Excellent.
Good timing.
All right, so here are a bunch of resources for you if you're interested in looking at our data set, at the statute, all on OIC's website. And if you have any questions, you can reach out to any of us and we would be happy to answer them.
Great, thank you. I see that we have a question from Mary Ann. Are ED or other facility services ever surprise backed billed?
So this is Jane. Surprise back billed. The statute basically is in effect for services received on or after January 1, 2020. So there is no balance billing for emergency services received after January 1, 2020.
Okay, thank you. Let's see. I have a question. Earlier in the presentation, you mentioned that if there were funds due back to the patient, that there was a 30-day refund period. I was wondering if you know how that's being monitored, or if that's at the discretion of the billing department to refund the overpaid funds, or how that would work.
So that's a great question. I mean, this is an obligation that is the provider's obligation. And now I'm going to sound a little bit bureaucratic, but the Office of the Insurance Commissioner has the authority to regulate insurers. We do not regulate providers.
Okay.
What we can do is, if we are aware by statute, if we're aware of a pattern of violations of the Act by a provider, for example, a provider who is balance billing, or a provider who overcharged somebody's cost sharing and now, needs to recoup that, we actually can refer it to our State Department of Health and to the licensing entities that oversee those professionals, because we essentially make a pattern of violations of the Act unprofessional conduct under our state's Uniform Disciplinary Act, which we are not aware of any other state that has done that.
Well, thank you. And I see Elizabeth has a question. For claims prior to 2020, are you able to identify providers who are doing balance billing the most?
Unfortunately, we are not. The insurers know, and via the APCD, we know whether a claim that was submitted was an out-of-network claim. But what we don't know is whether providers actually did issue balance bills. And I know I think a lot of the states who've engaged in this kind of work in balance billing, state level balance billing protection legislation, have relied upon data from Kaiser Family Foundation and other national studies that look at the extent to which people are actually receiving balance bills.
Okay, thank you. And we do have a question from Emerson. I believe this would be for you, Carol. I'm also interested in the answer to this question. Was the Oregon source from the Oregon Health Authority? Thank you.
I apologize here again. I don't know. I'm going to need to follow up with Amy Kinner unless someone else knows. I think you're referring to avoidable ED visits, but I'm not sure. So,
I think that was probably the follow-on from the original question, which isn't it's not in the QA session box any longer. Sorry.
Okay.
Thank you.
Yeah, I believe it was a measure that was originally created in the state of Oregon, but I don't know which agency created it.
Okay.
There was an algorithm that was created at New York University several years ago, probably 15, 20 years ago, by Professor Billings. And I think that's become the basis for many of these iterations in the future. That algorithm is still around if people are interested in it. And I think people have on it.
I'm familiar with that algorithm. I'm not sure that that's what this was, but it's based on a bunch of diagnosis codes, I can tell you that. I'll have to follow up with Amy Kinner on that one.
Well, thank you very much. If there aren't any other questions, I would like to thank our presenters today for these relevant and insightful presentations and their time. And thank you, audience, for joining us. I would ask also that you take some time to complete the survey that will help us with our presentations, feedback, and thank you again for joining us, and enjoy the rest of your afternoon. And thank you again.